Welcome to Mastering the Brachial Plexus, part of the StudyNeuro lecture series. In this video, we'll focus on the anatomy that really matters in clinical practice. You'll learn how the roots, trunks, divisions, cords, and branches are organized, and which nerves control key movements and sensations in the arm. By the end, you'll be able to identify the major branches, understand their functional roles, and connect anatomical knowledge directly to clinical scenarios. Let's simplify this complex network and make it practical for real-world use. The brachial plexus is a complex network of nerves formed by the ventral rami of C5 to T1. It coordinates both movement and sensation in the shoulders, arms, and upper chest. When these nerves are injured or affected by disease, patients may experience pain, numbness, or significant weakness. A solid understanding of this anatomy is essential for guiding treatment, planning rehabilitation, and optimizing patient care. Knowing the brachial plexus is crucial for linking clinical signs to anatomy. Weakness in the shoulder, arm, or hand directly points to specific nerve roots, helping localize injuries and predict recovery. It guides surgical decisions, from choosing donor nerves to planning efficient nerve transfers. It also reduces risks during procedures like regional anesthesia or fracture repair near the clavicle or humerus. Finally, a clear understanding of the plexus improves interpretation of MRI, ultrasound, and electrodiagnostic studies, allowing precise identification of injury sites. The brachial plexus starts with the roots from C5 to T1, which merge to form the superior, middle, and inferior trunks. Each trunk then splits into anterior and posterior divisions, which regroup into three cords: lateral, posterior, and medial. Finally, these cords give rise to the terminal branches that control the muscles and skin of the arm, including the musculocutaneous, axillary, radial, median, and ulnar nerves. Some important branches also come off along the way, like the suprascapular, dorsal scapular, and pectoral nerves, supplying key shoulder and chest muscles. When we look at a peripheral nerve in cross-section, it's organized into three protective layers, each with a specific role in function and healing. At the most microscopic level, individual axons are supported by a delicate connective tissue that maintains their metabolic environment and shields the nerve fibers themselves. These axons are then grouped into bundles or fascicles, which are wrapped by a specialized cellular layer that preserves fascicular structure and forms the critical blood-nerve barrier. Surrounding everything is a tougher outer layer that holds the nerve together, protects it from mechanical stress, and carries the blood vessels supplying the nerve. From a clinical perspective, the extent of nerve injury depends on which of these layers is disrupted. Preserving the fascicular covering is especially important, as it is associated with better surgical outcomes. Understanding this layered anatomy directly informs operative decisions, including whether neurolysis is sufficient or whether nerve grafting and more complex repair techniques are required. The brachial plexus begins with roots C5 to T1, which exit the spine and pass between the scalene muscles. Each root carries both motor and sensory fibers. C5 powers elbow flexion, C6 extends the wrist, C7 controls the triceps, C8 flexes the fingers, and T1 manages fine hand movements. Key branches like the dorsal scapular and long thoracic nerves emerge here. These roots unite to form the trunks of the plexus. Clinically, root injuries produce predictable patterns of weakness or numbness, and avulsions require nerve transfers since they cannot be directly repaired. At the root level, key branches arise early, including the dorsal scapular nerve to the rhomboids and levator scapulae, and the long thoracic nerve to the serratus anterior. The roots then combine to form the upper, middle, and lower trunks. Injuries at this level cause characteristic motor and sensory deficits, and when roots are avulsed proximally near the spine, they cannot be repaired directly, making nerve transfers essential for restoring function. After the brachial plexus trunks form, each splits into two pathways. Think of these as flexor and extensor routes, one heading to muscles that bend the arm and hand, the other to muscles that straighten them. Under the clavicle, these pathways regroup around the axillary artery into three cords. The lateral cord supplies the muscles that flex the arm, the posterior cord powers the extensor muscles, and the medial cord contributes to hand movements, including the ulnar and part of the median nerves. Clinically, injuries at the cord level leave the upper roots intact but can still seriously weaken the arm and hand. These cords are also the preferred sites for nerve transfers, helping restore function when specific nerves are damaged. The brachial plexus ends in 5 key nerves, each controlling specific movements and sensations. The musculocutaneous nerve flexes the elbow, the axillary nerve lifts and rotates the shoulder, and the radial nerve extends the elbow, wrist, and fingers. The median nerve enables thumb and finger flexion for precision grips, while the ulnar nerve powers fine movements of the hand's small muscles. Each nerve also carries sensation from distinct areas of the arm and hand. Because distal injuries produce specific motor and sensory deficits, knowing these patterns is essential for accurately localizing nerve damage. Understanding the key anatomical landmarks of the brachial plexus is crucial, both for clinical assessment and surgical planning. The scalene triangle is where the roots and trunks of the brachial plexus emerge, making them particularly vulnerable during traction injuries. The clavicle region carries the divisions, which can be compressed and fractures. Fractures of the cervical spine can also lead to root avulsions. Beneath the clavicle, the cords wrap around the axillary artery, and high-speed trauma can injure both the nerves and the artery, potentially causing serious complications. In the supraclavicular area, the phrenic nerve runs along the anterior scalene. An injury here can cause diaphragmatic paralysis. The spinal accessory nerve lies posteriorly and serves as an important landmark in surgical approaches. The infraclavicular area is ideal for identifying the musculocutaneous nerve and performing Oberlin transfers, where fascicles from the ulnar or median nerves are redirected to restore biceps function. For surgical access, the posterior triangle provides a corridor to the roots and trunks, while the deltopectoral groove allows safe access to cords and terminal branches. Some injuries of the brachial plexus and its branches lead to characteristic clinical syndromes. Erb's palsy involves the upper trunk from C5 to C6 and produces the classic waiter's tip posture, with the arm held close to the body, internally rotated, the elbow extended, and the forearm pronated. In contrast, Klumpke's palsy affects the lower trunk, C8 to T1, leading to weakness in the intrinsic muscles of the hand and the typical claw hand appearance. Individual nerve injuries also produce recognizable patterns. Damage to the radial nerve results in wrist drop, while injury to the ulnar nerve causes clawing of the ring and little fingers. Median nerve injury, on the other hand, weakens thumb opposition and can create the characteristic ape hand deformity. The brachial plexus begins with roots C5 through T1, which give rise to the dorsal scapular and long thoracic nerves. Injuries at this level can cause a winged scapula or weakness in shoulder elevation. From the upper trunk, the suprascapular nerve emerges, so damage here may lead to weak shoulder abduction and external rotation. Finally, the cords give rise to the major terminal nerves, the musculocutaneous, median, ulnar,
axillary, and radial nerves, where injury can result in arm flexion weakness, claw hand, wrist drop, or sensory loss in their respective distributions.
The brachial plexus may look complex, but its logic is consistent. Each segment carries a predictable role in movement and sensation. When you understand where a nerve comes from, you immediately understand what happens when it's injured. This framework helps you localize deficits, plan management, and interpret clinical findings with confidence. Keep revisiting the patterns, link them to patient cases, and the entire plexus becomes intuitive, not intimidating. Thanks for watching. Don't forget to like, share, and subscribe to Study Neuro for more clear, high-yield neuro content every week. Share your key takeaway below and stay tuned for more neurosurgery made simple.